So good evening, everyone. Hope you are doing well. In today's lecture, my lecture number 72 of my lecture series, we are going to go through a mock diabetes exam, which will be extremely helpful for you all in the upcoming specialty certificate exams and the European board exam. If you like to subscribe to my full lecture series, which is a series of 72 lectures till date, then you can directly email me on my email ID mentioned here, as well as you can WhatsApp me on my WhatsApp number. Please note that currently there are 72 lectures, but the subscription gives you lifetime access to the current existing 72 lectures, plus all the lectures which I'll be recording on the, in the coming years and months. So it's basically a lifetime access. So idea about the dates for the upcoming exam. We all know that there is an exam coming up next month on the 12th of June, and I wish everyone who has applied for the June exam all the best. There is another exam which is on the 13th of November for the specialty certificate. So in this particular year, they are running two dates for the exam. One is the 12th of June and the other is the 13th of November. Remember, the application period for the 13th of November exam is between 25th of July to 21st of August. I wish you all the best for the upcoming exams. A quick review of my lectures so far. These are all the topics which I have covered in my diabetes lectures, almost around 20 different topics, extremely helpful for the exams, covering the Joint British Diabetic Society guidelines, as well as the NICE guidelines and the DVA. So, extremely helpful because these are the commonly asked topics and themes from the diabetes section. Then there is around almost 15 lectures now on the high yield topics, and this includes Oxford Handbook quick review, some pearls from the Oxford Handbook, and some of the recalls from the previous specialty certificates and the European board exam. Extremely helpful set of lectures which will allow you quick revision before the exam. In terms of the thyroid, again, all the important topics which are tested in the exam have been covered in this 7 to 8 lectures. Then adrenal, again, all the important topics occurring commonly in the specialty certificate and the European board exams have been covered here. Two important lectures by Dr. Velmurugan on lab endocrinology, extremely helpful for those preparing for DNB and DM endocrinology. Pituitary, again, different topics covering the wide spectrum which appears in the exams. Three sections on inherited endocrine syndromes, around 7 lectures across various topics of reproductive endocrinology, 3 lectures on calcium and bone metabolism, 2 important sessions on familial lipid disorders and NICE lipid guidelines. In terms of pediatric endocrinology, there is one session on delayed puberty, covering the spectrum of Kalman and Klinefelters. Now let's start right away for your questions. So question number 1, we have a 42-year-old female with insulin-treated type 2 diabetes. She's admitted electively under the care of a surgical team for hernia repair. Currently taking aspart 20 units TDS and insulin glargine 36 units daily. Her HbA1c is 64 millimole per mole, which is around 8%. And she has a capillary blood glucose value of 11 millimole per liter. Which of the following is an indication to start on a variable rate intravenous insulin? The fact that she's taking insulin treatment, HbA1c of 64 millimole per mole, capillary blood glucose of 11, if she's anticipated to have a long starvation period, that she's going to miss 2 or more missed meals, and hypoglycemia during the period. So think about this like an exam. Look at the options, look at the question stem, and we'll move on to the answer in the next slide. So let's move on to the answer. If she's anticipated to have long starvation period is the correct answer, which will be an indication to start her on a VRIII. That is 2 or more missed meals a long starvation period. So this comes from the JBDS guidelines, which were updated in December 2022. These are guidelines for perioperative care for people with diabetes mellitus undergoing elective and emergency surgery. The basic principles extremely important. There is no one fit for all. The variable rate intravenous insulin infusion is the preferred method for managing the surgical patient's glucose in the following circumstances. So each and every statement is very important here, and that is the options. And they have tried to confuse with digits and the numbers in this. So people with type 1 or type 2 diabetes undergoing surgery with a fasting period with more than one missed meal. So that's clearly the answer here, which is D. People with type 1 diabetes undergoing surgery who have not received background insulin, but our patient had received background insulin. People with suboptimal diabetes management defined as HbA1c of more than 8.5% or more than 69 millimole. Our patient had 64 millimole. Again, that did not fit that criteria. Most people with diabetes and requiring emergency surgery, but our patient was undergoing elective surgery, and people with persistent hyperglycemia, CVG more than 12, our patient had CVG of around 11. What is important during VRI, we need to note that if the patient is already on long-acting insulin, we definitely need to continue that, but we can go down to around 80% of the usual dose. Insulin requirements often vary with weight. Insulin infusion rate should be determined by the bedside capillary blood glucose measurement, and this should be done on an hourly basis. Let's move on to question number 2. We have a 55-year-old man who presented to the diabetes foot clinic with a plantar foot ulcer on the right foot. Podiatrist can probe the ulcer down to the bone, and there is a significant purulent discharge. According to Wagner classification grade of diabetic foot lesions, what grade of ulcer does the patient have? Is it grade 1, 2, 3, or 5? 4 or 5? Think about the options. Look at the question stem. And let's go on to the answer in the next slide, which is grade 3. The correct answer here is grade 3. And what is a Wagner's grading system? Grade 1 is just a superficial diabetic ulcer. Grade 2 is ulcer extension, which involving the ligaments, tendon, joint, capsule, or fascia, but there is no abscess or osteomyelitis with grade 2. Grade 3 is our answer, and the patient had deep ulcer with abscess or osteomyelitis. Grade 4 is already gangrene, which has started up to the portion of forefoot, and grade 5 is extensive gangrene of the. Question number 3, which of the following is not a component of Sinbad system for classifying and scoring foot ulcers? Is it the ischemia? Is it the area? Is it the neuropathy? Is it dryness? Or is it the cell? So think about again the question stem. We are talking about the Sinbad system here, asked commonly in exams. The correct answer here is dryness. Dryness is not a component of the Sinbad system. So what is the Sinbad system? We have side, forefoot gets a score of 0, whereas if the midfoot and the hindfoot is involved, that's a score of 1. Pedal flow intact, 1 pulse palpable, 0. Clinical evidence of reduced pedal flow, score is 1. Neuropathy is also a component, protective sensation intact, 0. Protective sensation lost, 1. Bacterial infection, if it is none, 0. Then present, it is 1. If area of ulcer is less than 1 centimeter square, the score is 0. Ulcer more than 1 centimeter square, score is 1. Depth, ulcer confined to skin and subcutaneous tissue is 0, whereas ulcer, if it is reaching the deeper muscle, tendon, or deeper, the score is 1. So total possible score is between 0 to 6. Of course, higher the score, the more bad the ulcer. So all these are components of the Sinbad staging for score classifying and scoring foot ulcers, but dryness is not a component of it. Moving on to question number 4, we have a 45-year-old male known to be type 1 diabetic for 23 years, admitted to the hospital with community-acquired pneumonia. His pre-admission insulin regimen was as follows. He was getting long-acting insulin, Glargine, 34 units before bed, and Lispro. Insulin, actually, it's Humalog, which is Lispro, not Novorapid. It's 6 units before each meal. On the afternoon of the second day of his admission, he reported feeling sweaty, clammy, shaking, and his blood glucose was found to be 2.6 millimole. He had an hypoglycemic episode. He's fully conscious. What is the next immediate action to take? So here again, they are testing a JBDS guidelines. Think about the options now. Give the patient glucosate 100 to 150 ml. Give 2 tablets of dextrosol followed by 2 biscuits immediately. Give 7 tablets of dextrosol followed by biscuits when BM is more than 4. Give intravenous glucose 10%. Reduce his morning dose of short-acting insulin. So what is the possible answer? Think about it again. This is based on the guidelines. So the correct answer is give patient 7 tablets of dextrosol followed by biscuits when the BM is more than 4 millimole per ml. And this comes from the revised January 2023 guidelines based on the hospital management of hypoglycemia in adults with diabetes mellitus from the JBDS. And that's how they have given the algorithm for management of hypoglycemia in patients with diabetes in hospital. Mild adults who are conscious, oriented, and able to swallow, check ABCDE, stop IV infusion if running, give 15 to 20 gram of quick acting carbohydrate, which is what we gave in this particular patient, such as 5 to 7 tablets of dextrosol, or 4 to 5 lift glucotabs, or 150 to 200 ml of pure fruit juice. Test blood glucose level after 10 to 15 minutes. If it is still less than 4 millimole, repeat treatment as above, and this can be done up to 3 times. If still hypoglycemic, call doctor, consider IV dextrose or IM glucagon as per the severe pathway. Then, in this case scenario as well, check blood glucose after 10 to 15 minutes. Once blood glucose levels are more than 4 millimolar or above, give 20 gram of long-acting carbohydrate like 2 biscuits, as we had given in this patient, a slice of bread, 200 to 300 ml of milk, or next carbohydrate containing meal. Give 40 gram of IM glucagon for patients with enteral feeding tube. Give 20 gram quick acting carbohydrate via enteral tube, which can be 50 to 70 ml of Ensure Plus or 40 juice. What's important here to note is if the patient who had received glucagon initially, then in this case, the long-acting carbohydrate, we need to give 40 grams instead of 20 grams. That's also an important question which has been asked in the exams. So this is something which you should keep in mind from the guidelines. What about if the patient was conscious and able to swallow but confused, disoriented, and aggressive? In this again, check ABCD, stop IV infusion. If capable and cooperative, treat for mild hypoglycemia. As for mild hypoglycemia, if not capable and cooperative, but can swallow, give 2 tubes of 40% glucose gel, squeeze into the mouth between the teeth and the gums. Test blood glucose level after 10 to 15 minutes, and if still more less than 4 millimole, repeat as above up to 3 times. If still hypoglycemic, move on to the considering IV dextrose or IM glucagon as per the severe path. Again, as regards stabilization with a long-acting carbohydrate, the same principle applies as we mentioned for the mild pathway. What about severe? If the patient is unconscious, fitting, or aggressive or nil by mouth, check ABCDE, stop IV insulin, request medical support, give 100 ml of 20% dextrose, very important. Again, several questions have been asked with this particular concentration. So give 100 ml of 20% dextrose or 200 ml of 10% dextrose over 15 minutes. And this is the latest update, so you all should know this for the exams. If IV access not possible, using 1 mg glucagon, not access, use 1 mg glucagon IM, recheck blood glucose after 10 minutes, and if still blood glucose is less than 4, repeat treatment as above. So repeat testing blood glucose always at 10 to 15 minutes. If blood glucose now 4 millimolar or above, follow up treatment as described on the left side. If NBM once glucose more than 4 millimole, if the patient continues to be nil by mouth, and once the blood glucose is more than 4 millimole, we should then consider giving 10% glucose infusion at the rate of 100 milliliter per hour until no longer nil by mouth or reviewed by the doctor. What's very important is do not omit subsequent insulin doses, continue regular capillary blood glucose monitoring for the next 24 to 48 hours, review the patient's insulin and oral hypoglycemic doses if they need adjustment. If previously on IV insulin, we should generally consider restarting insulin once the blood glucose is more than 4, but may require review of the regimen. Glucagon may take up to 15 minutes to work and may be ineffective in treating hypoglycemia in undernourished patients. So this is what we need to take into context, especially alcoholics in severe liver disease, if it is a sulfonylurea-induced hypoglycemia and in repeated hypoglycemia. So in this case, glucagon may be taking a longer time to work or maybe even ineffective. So we should then consider giving the patient IV dextrose for that one. Move on to question number 5. We have a 52-year-old man admitted electively for repair of his inguinal hernia. He is known to have type 1 diabetes for 30 years, uses a basal bolus regimen, insulin glargine 12 units in the morning, Novorapid 6 minutes before each meal. His operation will be at 9 a.m. in the morning. His most recent HbA1c was 55 millimole per mole. So, what advice will you provide him with regards to his insulin therapy preoperatively? Again, this is based on the latest JBDS guidelines. Number one, does he need to omit his long-acting insulin on the day of the surgery? He needs to stop all his insulins and go on to VRII. He should omit his Novorapid in the morning and lunchtime only while reducing the doses of morning glargine. Remember, he's taking glargine in the morning. He should only reduce his long-acting insulin by 20% prior to surgery and leave his Novorapid the same. Or he should reduce his lunchtime Novorapid and morning Levemir doses. He's not on Levemir anyway. So think about these options and what will be the best possible answer based on the guide. So the correct answer will be he should omit his morning doses of Novorapid and lunchtime and should consider reducing the amount of glargine which he's taking in the morning. So this is based on the JBDS guidelines updated in December 2022. These are the guidelines for perioperative care for people with diabetes mellitus undergoing elective and emergency surgery. So clearly the guidelines has been mentioned when we talk about the long-acting insulin, if the patient is taking that in the morning, like in this case scenario, on the day prior to admission, no dose adjustment is necessary. Simple. Patient for the morning surgery, as this patient, give 80% of the dose, so that is what we are reducing. And even if the patient is for PM surgery, give 80% of the dose. If the patient is taking once daily long-acting insulin, but as lunchtime, again, day prior to the admission. So, for example, if we are talking about a patient is getting once daily long-acting insulin, but taking it at the lunchtime, then day prior to admission, give 80% of the dose. Patient for AM surgery, restart insulin at normal dose when eating and drinking starts. And for patient for PM surgery, again the same thing. What about if the patient is taking once daily long-acting in the evening? Then day prior to admission, we give 80% of the dose. Patient for AM surgery, of course, no dose adjustment would be necessary. And for PM surgery, also no dose adjustment. On the other hand, if the patient is on twice daily long-acting insulin, the morning dose will need to stay the same. Evening dose will be reduced by 80%. This is on the day prior to the admission. If the patient is for the morning surgery, morning dose will need to be 80% and blood glucose needs to be checked on admission. The evening dose will remain unchanged. If the patient is for the evening surgery or PM surgery, morning dose will need to be 80% and blood glucose will be need to checked on admission. The evening dose will continue to remain unchanged. So these are the guidelines for the patients undergoing elective and emergency surgery surrounding long-acting insulin. What about short-acting insulin? Short-acting insulin, which patient of course takes with the meals 2 to 4 times a day. This includes all of the short-acting insulins which we know of. On the day prior to admission, no dose adjustment is necessary for any one of them. If the patient is for the morning surgery, as this patient, omit the morning dose if no breakfast is taken. Omit lunchtime dose if the patient is not eating yet. And once the patient goes back to his normal eating, then we can go to his normal dose. If the patient is not eating enough or eating half, then we can give half the usual dose for it. What if the patient is from evening surgery? The morning dose will remain the same with the breakfast because patient will have the breakfast. Most likely he will not have the lunch, so he will omit the lunchtime dose. And evening dose will of course be if the patient has gone for surgery, the evening dose will be skipped. If the patient is back from the surgery, is going to have the dinner, then resume the normal insulin with the evening meal if eating a normal meal. If the patient is not eating enough or not having much appetite, we can give half the usual evening dose. So resume taking usual insulin therapy in the morning after the surgery procedure. However, blood glucose levels may remain higher than usual for a day or so because of the adjustments which. What about the variable rate intravenous insulin infusion? As I mentioned previously in my slide, the dose of the long-acting insulin, if the VRI is started, should be reduced to by around 80%. Short-acting, intermediate, and premixed insulin should be discontinued and replaced by long-acting basal insulin at the dose of 0.2 unit per kilogram. And then once the patient goes back to his normal eating and drinking, we can go back to his usual dose. On to question number, actually it's a question number 6 for you all. 62-year-old man with type 2 diabetes has intermittent claudication. His HbA1c is 46 millimole per mole, and he takes the following medication, which is atorvastatin, ramipril. His foot pulses are weak, non-palpable. He has evidence of sensitive neuropathy. Which of the following interventions are recommended immediately? Should the patient join a gym to improve on the exercise, offer angioplasty to help reduce symptoms? Aspirin should be prescribed, commence naphtidrofuryl oxalate, or should we measure a ankle brachial pressure index? Think about this question number 6. Read the question stem again. Look at the options. Correct answer is measure an ankle brachial pressure index. So this is also based on the NICE guidelines about peripheral arterial disease diagnosis and management. These are the CG 147 guidelines for peripheral arterial disease assessment. They clearly indicate measuring an ankle brachial pressure index if we suspect an arterial disease, as in this patient. Only offer duplex ultrasound if revascularization is considered. Clopidogrel 75 mg is a preferred antiplatelet. We should advise a supervised exercise program for 3 months, at least 2 hours per week. Modify any risk factors. Only use naphtidrofuryl oxalate if supervised exercise program fails and the patient is not suitable for angioplasty or bypass surgery. The important points from the CG-147 NICE guidelines, which has been tested in this question. Question number 7. 60-year-old woman with admitted for elective laparoscopic cholecystectomy, known to have type 2 diabetes, uses metformin 1 gram twice daily, sitagliptin 50 milligram once daily, and dapagliflozin 10 milligram once. Her more recent HbA1c is 48 millimole per mole, admitted overnight in preparation for an operation next morning. 2 hours before she was supposed to be transferred to the theatre, she was found to have a high blood glucose of 17 millimole per liter, and her capillary blood ketones came positive at 1.5 millimole per mole. What is the next best action to do? Treat as DKA, 2.1 unit per kg of subcutaneous rapid-acting insulin, and recheck the blood glucose at 1 hour. Inform the theatre to cancel surgery, give a start dose of long-acting insulin, and proceed to surgery, or no action is required. Again, guidelines has been tested in this question. So go through the question step again. Look at the options. The correct answer is give 0.1 unit per kg of subcutaneous rapid-acting insulin and recheck blood glucose in 1 hour. Again, these are from the guidelines which I mentioned for the perioperative care. Important points which are mentioned for management of perioperative hyperglycemia, which is a CBG of more than 12 millimole per liter, for as in this patient. Rule out hospital-acquired DKA, perform capillary glucose if the patient with diabetes is unwell or if the CBG is more than 30. If ketones are more than 3, treat as DKA. Identify and remedy cause of hyperglycemia, ensure basal insulin is covered for. Rule out HHS. HHS is characterized by profound hypovolemia, hyperglycemia, and osmolarity, which is more than 320. If evidence of HHS, go for HHS guide. If on insulin pump, refer to the insulin pump guidelines. What about the insulin correction doses? This is very important to note. We should know about the insulin correction doses in this scenario for type 1 as well as for type 2 diabetic patients. Now, patient was type 2, remember? So, looking at the principles for the type 2 insulin correction, give 0.1 unit per kg of subcutaneous rapid-acting insulin and recheck blood glucose in 1 hour to ensure it is falling. This is as per the guidelines if you notice in the perioperative hyperglycemia. Repeat the subcutaneous insulin after 2 hours if the blood glucose is still about 12 millimole per liter. In this situation, the insulin dose selected should take into account the response to the initial dose. Consider doubling the dose if response is inadequate, but note the risk of hypoglycemia with stacking of the insulin in fast phase. Repeat the blood glucose again after 60 to 90 minutes. If it is not falling still, consider putting the patient on variable rate insulin. What is the principles for insulin correction for people with type 1 diabetic? Use subcutaneous rapid-acting insulin. Assume that 1 unit will drop the blood glucose by 3 millimole, but whenever possible, take advice from the person with diabetes about the amount of insulin he is normally requiring to correct his blood glucose. Recheck the blood glucose again at 1 hour, ensure it is falling. Repeat this up to insulin dose after 2 hours if blood glucose is still above 12 millimole, almost similar to one which we are doing it for the type 2 diabetics. In this situation, the insulin doses selected should be taken into account the response to initial dose. Same principle. Consider increasing the dose if it is an inadequate response to the initial one. Recheck the blood glucose after 1 hour. If it's not falling still, consider again putting the patient on a variable rate insulin infusion. So, two important things. The first lines for both the things are important principles tested in the exam. In case of type 1 diabetics, 1 unit drop down by 3 millimole. For type 2 diabetics, give zero point 0.1 unit per kg of subcutaneous rapid acting insulin and recheck the blood glucose in 1 hour, which was the answer for this question number 7. Question number 8, we have a 70-year-old man known to suffer from type 1 diabetes lifelong. He was admitted 3 days ago with a total anterior circulation stroke complicated by aspiration pneumonia. Now, he usually has insulin glargine 20 units at night and insulin novorapid before meals. Despite all active medical treatment, his general condition has deteriorated, and the team decided that he needs to go on to the end of life care pathway. He is unconscious. In patients with type 1 diabetes who are approving their last few days of life, what is the next action to do? Should we switch his insulins to VRII? Should we stop all his insulins but monitor his blood glucose 4 times daily? Should we stop his glargine and continue the novorapid 3 times daily? Should we continue glargine and adjust the dose according to the evening BM? Or should we check glucose frequently and give stacked doses of novorapid if it is more than 15 millimoles per liter? Again, a very important guidelines tested in this question number 8, very important for exams. So look at the question, answers, and this is the correct answer. Continue glargine and adjust the dose according to the evening blood glucose. So this is based on the February 2023 inpatient care of the frail older adults with diabetes guidelines. So these were recently updated. Before there was an end of life guidelines, but they have been now incorporated in this guidelines. So we should read up this guidelines. Very, very important. Let's look at the important principles for this guideline. Algorithm for the last days of life. Type 2 diabetic patient, diet control or metformin treated, stop monitoring blood glucose. Now, when we talk about a patient who is type 1 diabetic, let's move on to type 1 diabetes. Continue once daily morning dose of insulin with reduction in the dose to be considered. This is we are talking about the long-acting insulin as we did in this patient. And we should check the blood glucose once a day at tea time, which is the evening. So that was the answer. According to the evening BM, will adjust the doses. If it is below 8 millimole, reduce the insulin dose by 10 to 20%. If it is above 20 millimole, increase the insulin dose by 10 to 20% to reduce the risk of symptoms or ketosis. So this is very important in context of type 1 diabetes patients who are on insulin only. We continue their long-acting insulin only and we check their evening blood glucose and then adjust the doses of the long-acting insulin accordingly. What about patients of type 2 diabetes on other tablets other than metformin and or insulin and or GLP-1 receptor agonist? You should consider stopping all the tablets and the GLP-1 receptor. Consider stopping insulin if the individual only requires a small dose and the blood glucose readings are all less than 10 millimole. If the insulin is stopped, if blood glucose is over 20 millimole, give 6 units rapid-acting insulin such as Aspart, Lispro, Rapidra. Recheck blood glucose after 2 hours. If the individual requires more rapid-acting insulin, more than twice, consider daily isoflurane insulin or long-acting insulin like glargine or degludec. If insulin is to continue, prescribe once daily morning of isoflurane or long-acting glargine insulin based or, for example, Tresiba as well, which is degludec, based on 25% less than the total previous insulin dose. And then we can follow the same principle as we did for the type 1 diabetics by adjusting their doses as per the evening blood glucose. So important information further, aim for capillary blood glucose between 6 to 15 millimole per liter. For this is the algorithm for the last days of life. Keep tests to minimum. It may be necessary to perform some tests to ensure unpleasant symptoms do not occur due to low or high blood glucose. It is difficult to identify symptoms due to hypo or hypoglycemia in a dying person. If symptoms are observed, it will be due to abnormal blood glucose. Test urine or blood for glucose if the person is symptomatic. Observe for symptoms in previously insulin-treated individuals where insulin has been discontinued. Flash glucose monitoring may be useful in these individuals to avoid frequent finger prick testing. So again, very important set of guidelines, as I mentioned, very important for the exams. Moving on to question number 9, we have a 65-year-old male presented to the emergency department with abdominal pain, nausea, vomiting, shortness of breath for the last 4 hours, past medical history of hypertension, angina, type 2 diabetes, sleep apnea. Recently diagnosed with heart failure and had a cardiology review 8 weeks ago where anti-heart failure medications were commenced. Medications include furosemide, clopidogrel, bisoprolol, empagliflozin 10 mg, ramipril 10 mg once daily, atorvastatin, and metformin plus sitagliptin twice. On examination, he looked dehydrated and in distress. No leg swelling, no rise in the GVP, chest auscultation clear. Abdominal examination revealed mild abdominal tenderness but no rigidity. Heart rate tachycardic, blood pressure on the lowest side, saturation 97% in room air, and temperature of 40. These were his labs on the day of admission. We can clearly see that the patient's pH is around 7.25, which is low. Venous bicarbonate is pretty low at 11. HbA1c is 55. Clearly, this patient looks. So think about the options, and it seems the patient have some renal impairment as well. So clearly, the eGFR has dropped down to 29 from 95, 307. What is the next best course of action? Request abdominal CT to rule out acute pancreatitis. Request an ABG. Request an urgent capillary ketone measurement. Refer to the renal team for urgent dialysis or stop metformin. So clearly, you should look at these things. Look at the medication the patient is on, lab pattern, and the next best action to do is to request an urgent capillary ketone measurement. Why? Because this patient has developed DKA. This is classically euglycemic DKA, as you can see, because his venous glucose was 9. Clearly, the patient was acidotic. Only thing we needed to check for the ketones, and that's why the correct answer was requesting an urgent capillary ketone measurement. This patient was on an SGLT2 inhibitor, empagliflozin, which had precipitated the euglycemic DKA in this patient. This condition is treated in exactly the same way as hyperglycemic DKA. Initiate glucose 10% straight away at 125 ml per hour because the glucose is already at less than 14 millimole per liter. Begin with 0.1 unit per kg per hour insulin rate. If blood glucose falling despite 10% glucose, reduce the rate of insulin infusion to 0.05 unit per kg per hour to avoid. This is question number 10. Regarding the care of women with type 1 diabetes who are in labor, which of the following is true? Should we check capillary blood glucose every 2 hours while the patient is on a variable rate insulin infusion? CBG target in labor should be kept at 8 to 10 millimole per liter. Antiretroviral steroids are contraindicated given the risk of decay. During breastfeeding, it is advised to increase the daily calorie intake and stacking frequency. And the insulin pump or the continuous subcutaneous insulin infusion should be discouraged and VRIs should be used instead of insulin. So what is true regarding care of women with type 1 diabetes who are in labor? Again, guidelines are tested here. Correct answer is during breastfeeding, it is advised to increase the daily calorie intake and snacking frequently. Now, this has been incorporated in the Managing Diabetes and Hyperglycemia guidelines during the labor and birth. These were released in February 2023. Key recommendations clearly mentioned in these guidelines. All women with diabetes of any type should have an hourly blood glucose, be it capillary, flash, or CGM, monitoring in established labor or from the morning of the elective CS. If general anesthesia is used, monitoring should become every half an hour until the woman is fully conscious. Very important for exams. Aim to maintain blood glucose levels during labor in either the target range advocated in NICE guidelines, very commonly asked 4 to 7 millimole, or in the more liberal range of 5 to 8 millimole due to the lack of randomized controlled trial evidence of either type. Some women with type 1 diabetes, type 2 diabetes, or GDM may require variable rate insulin infusion to achieve target glucose. An example pre-printed prescription, we already saw that variable rate guidelines. So women who are on insulin pump therapy or automated insulin delivery system may choose to remain on the insulin pump therapy or the automated closed loop systems. after steroids, and during intrapartum and postnatal period as well. If VRI is, we don't need to discontinue that. If VRI is to be used, aim to achieve blood glucose in the pre-pregnancy in the pregnancy target range of 4 to 7.8 or 5 to 8 millimole. Always use capillary blood glucose to adjust the variable rate insulin infusion dose. Continue mealtime insulin where when VRI started if the woman is eating and drinking. This is again very important. If the patient is eating and drinking, we will continue the mealtime insulin with the variable rate insulin. On the other hand, if the patient is NPO, we'll just continue the variable rate insulin. If the variable rate insulin infusion is used, the default fluid to run alongside should be 5% glucose in 0.9% saline with 0.15% KCl at the rate of 50 ml. This is little different from the standard fluid to be used. I will be showing that to you in the next subsequent slide. So in terms of management during labor, this is the particular fluid which we should be using in the VRI, the default fluid which we should run alongside uh, should be 5% glucose in 0.9% normal saline. Always contact the diabetes team to review ongoing post-insulin doses in insulin-treated patients with type 1 and type 2 diabetes. The insulin doses may be 25% less than the doses needed at the end of the first trimester. Women with type 1 diabetes are at increased risk of severe hypoglycemia, especially when breastfeeding, and should have an additional carbohydrate with meal or a snack available during or before breastfeeds. So this is extremely important for I mean, we have already seen this question appear now in this section. Glucose levels over 6 millimole are advised before each breastfeed and before bed. So this paragraph is basically in our question, and this is what was asked in this particular question. So glucose lowering medications in women with gestational diabetes should be stopped after delivery of the placenta. Continue monitoring glucose for up to 24 hours to exclude diabetes. Women with pre-existing type 2 diabetes or breastfeeding can take metformin after birth but should avoid other glucose lowering aids. Capillary blood glucose levels should be monitored regularly when women are administered steroids in pregnancy. Again, administration of antenatal steroids is crucial for fetal lung maturity and should be considered in all women at risk of preterm birth up to 35 plus 6 weeks of gestation. Women who are on insulin pump may choose to continue on the insulin pump unless they are not able or not willing to continue pump during labor. As breastfeeding and expressing breast milk can both increase the risk of maternal hypoglycemia, women should be advised to take extra calories up to 450 extra calories per day when feeding is usually established. So this is what was asked in the exam. I mean, what was asked in the question stem there. This is done by advising the woman to snack 10 to 15 grams of carbohydrate should be taken at and drink each time they feed or express the milk, including at night feeds. Indeed, insulin doses may need adjustments based on the calorie and carbohydrate. So this is the final question for the free group. Will be the question number 11. A 23-year-old man with type 1 diabetes diagnosed 2 months ago, complains of burning paresthesias affecting both feet and returning to the clinic. He has been started on novorapid and isoflurane insulin. Which of the following is characteristic of this condition? So basically type 1 diabetes, recently diagnosed, most probably a LADA, diagnosed at the age of 23 years, received novorapid and isoflurane insulin, and 2 months after starting the insulin, comes to the clinic with paresthesias affecting both the feet. Which of the following is characteristic of this condition? Is the nerve conduction studies are typically abnormal in this condition? Small fiber function is more commonly affected. I mean, the answer is already marked out here. Complete resolution of symptom is rare. Motor signs are often present clinically, and the weight loss is rare. So I'd already marked the answer here. The small fiber function is more commonly affected than the large fiber. And this is typically what is described in the question is insulin neuritis. This is also treatment-induced neuropathy of diabetes, also called insulin neuritis. Is an uncommon small fiber neuropathy that occurs in patients with chronic hyperglycemia who experience a rapid improvement in their glycemic control, as had this patient. The small fiber function is more commonly affected than large fiber is the correct answer in this one. The main clinical manifestations are severe treatment-resistant pain and autonomic dysfunction, along with worsening of retinopathy and nephropathy. It is acute onset of neuropathic pain or autonomic dysfunction within 8 weeks of a large improvement in the glycemic control. That is a decrease in the glycosylated hemoglobin of more than 2 percentage points over a period of 3 months. Risk of developing treatment-induced neuropathy or insulin neuritis and the severity of neuropathic pain and autonomic dysfunction correlated with the magnitude of decrease in HbA1c. The risk of this particular insulin neuritis was increased in type 1 diabetes or in the patients with a history of eating disorders. What is also important is that it has scant clinical signs. It may have associated weight loss. Peripheral nerve examination will be normal in this case scenario, and it is usually transient, self-limited within a period of 6 months. Typically occur with treatment using insulin or with oral hypoglycemic agents. Pathogenesis of insulin neuritis remains uncertain. Proposed mechanisms include endoneurial edema and ischemia, apoptosis from the glucose deprivation, and microvascular neuronal injury due to recurrent. Treatment is usually symptomatic. So that's the end of my free view. Uh, if you like to have a full access to this session, please subscribe to my lecture series by emailing me or WhatsApping me on this number. As you can clearly see, I have tried to cover around 52 questions in this particular slides. So if you like to have an access to my full lecture, which has 52 questions, which is a mock exam for diabetes, please subscribe to my full lecture series. So thank you so much. Hope you enjoyed the lecture.